Well, good morning. My name is Kira Barker, and on behalf of the LSU Health Sciences Center, New Orleans, Department of Psychiatry, I would like to thank you for joining us for today's webinar, Autism Spectrum Disorder, Evidence-Informed Family Supportive Services. The development of this project was a major undertaking, and we are deeply appreciative of the Institute of Mental Health for the funding to make all of this happen. We'd also like to acknowledge the Mental and Behavioral Health Capacity Project through the Gulf Region Health Outreach Program for leveraging funds to allow us to expand to locations surrounding the greater New Orleans area. So before getting into more specifics related to the project and today's presenters, I want to go over some logistical issues. The live webinar has been approved for continuing education credits for psychologists, social workers, and licensed practicing counselors in Louisiana. So for you to get your credits, you'll need to make sure to complete the evaluation survey at the end of the webinar. Once you have completed the webinar, we're going to send you a link to the survey, to the email that you used when you registered. So once you've received the evaluation, we will email you that certificate to the same address. If you live outside of Louisiana or you want to pursue continuing education credits with your board, please email me at cbark1@lsuhsc.edu. And we will provide you with the certificate of completion for the webinar. And if you need some other information for us, we can provide you that as well, so you can submit that to your board. We'll be unable to do live questions during the webinar, so if there are any questions or comments or concerns that you have that you'd like to ask the presenters, email me once again at cbark1@lsuhsc.edu, and I'll make sure that we get your questions addressed. If you experience any other technical issues, such as the web link is unable to work or there is some sound issue on our end, please call 504-568-2003. Okay, so getting finished with the logistical issues, I'm happy to tell you a little bit more about our project. So the development of this project emerged out of an ongoing collaboration with local providers and community organizations that noted a shortage of autism spectrum disorder related supportive services in the greater New Orleans area. And many of our partners thought that they would benefit from learning more about autism spectrum disorder and ways in which they would be able to provide support for children and families that were coming into their practices. So with the assistance of funding from the Institute of Mental Health, we proposed to design a true community-informed support program specifically to address family needs for children with ASD. In designing this program, we had three different objectives that we wanted to accomplish. First, we wanted to get information from community members, so family representatives, clinical providers, to determine what services are being used and what services are needed in our community. Second, as requested by some of our partners, we wanted to provide information to community members about autism spectrum disorder and related supportive services. So we worked to develop an extensive community resources guide for autism spectrum related disorders, related services that is now available on our website. And I'll have that link posted for you toward the end of the webinar so that you can save it if you would like to refer families for different services in the community. We also hosted a workshop that some of you may have attended this past summer that had more in-depth information about ASD, stress and resiliency factors, concerns for children as they emerge into adulthood, and medical and psychopharmacological concerns. So that was a big part of what we wanted to accomplish and help for the community in providing that information. So the final phase of this project, we wanted to create a manualized family-centered program that could be used by providers and community organizations to enhance autism spectrum disorder supportive services. So our primary goal was to make this manual one in which the community was able to provide input. So we integrated a mix of the needs highlighted from our community needs assessment that we're going to talk about later, and then empirical evidence from the research to start to put together this manual. Since this is a product that we really want to reflect the needs of our areas, we would greatly appreciate any type of feedback that from you all on what things you think may be helpful for this manual. So we're actually going to post our in-process rough draft and ask for you to provide feedback on what you would want to know, or other information that maybe we should include in the manual. So at the end of the webinar, we're going to post the link to the manual and a form where you can provide written feedback. So anything or any ideas that you could give, we would greatly appreciate. Okay, now with all of that said, I want to introduce our objectives for today and the speakers that will be discussing the different aspects of this project in more detail. First, we're going to have Dr. Tanya Hansel. She is a clinical associate professor, licensed social worker, and clinical researcher with the LSU Health Sciences Center Department of Psychiatry. She will be discussing findings from the Parent and Provider Community Needs Assessment on ASD-related services in the greater New Orleans area that we completed.
Hello and welcome. My name is Dr. Tanya Cross Hansel with the LSU Department of Psychiatry, and today I'll be discussing research identifying the supportive service needs for families living with an autism spectrum disorder. This research was funded from the grant by the Institute of Mental Hygiene. The purpose of the study was to understand the service needs of families living with an autism spectrum disorder in the greater New Orleans area and local providers' perceived needs for ASD services. We use both snowball and purposive sampling through word of mouth, outreach events, and collecting resources for the GNO ASD Resource Guide. Surveys were collected between May and October of this year, and we had 47 participants in the provider surveys and 99 participants in the family surveys. In the provider surveys, 53% were in private practice and 56% were direct practitioners. The majority of providers noted an increase in the past few years on the number of children with ASD being referred to their services and the proportion of children who use services with ASD traits. They also noted that the age of the child for which families seek services had not changed, that had stayed the same over the past few years. Some of the limitations they noted in providing ASD services were centered around funding, such as insurance reimbursement, funding shortages, Medicaid reimbursement, training, client transportation issues, scheduling issues, access to clients, and only 10% reported no limitations with ASD services. Providers were asked to endorse all services that they provide that are ASD specific, not ASD specific, but to individuals with an ASD diagnosis, or that they do not provide. The following list is less than 20% that do not provide any ASD specific or services to individuals with ASD. And those include parent mental health counseling, parent support groups, sibling mental health counseling, physical therapy, medication management, sibling support groups, respite care, and neurology services. We also ask a series of questions to gain a more in-depth understanding of service needs. From the results, we had 64 responses and revealed 7 themes. Those themes included supportive services and therapy, training and education, transitional age needs, funding and reimbursement, assessment and screening, coordination of services, and school-based services were all identified as service gaps on the qualitative responses. Moving on to the family surveys, 94% of those that responded were mothers and 6% were grandparents. 54% were 41 years of age or older. 76 were married or living with someone in a married-like relationship. 76% identified as white. 59% had greater than or equal to a 4-year college degree. And 52% had less than $60,000 income in 2015. We would like more variability in the future, although aside from income, these stats are similar to many other studies on families living with at least one member that has an ASD diagnosis. The majority of participants were reporting on a male child, and the number of siblings that that child has ranged from 0 to 7, with an average of 1.3 siblings. That makes the mode for the number of children in the household about 2. %87 of the siblings do not have an ASD diagnosis. The remaining percentage have 1 or 2 siblings with an ASD diagnosis. The primary diagnosis for the child that the parent was reporting on was autistic disorder, autism, Asperger's disorder, pervasive developmental disorder, and other. It's important to note that many of these diagnoses were received prior to the DSM-5 change in 2013. And so these would have been their specific diagnoses, even though some of them have been lumped into the ASD broader category now. The age of diagnosis for the child was between 1 and 18 years, with a mean of 4.27, meaning that most of the children in the study, the average age was right around the pre-kindergarten, kindergarten age. Greater than 20% reported additional diagnoses, including ADHD, developmental delays, anxiety disorders, and learning disabilities. Parents were also asked a number of questions on behavioral concerns, and the largest category was anxiety, where parents are concerned about anxious behaviors in their children. A little over a quarter of the participants also noted defiant oppositional behaviors, increase in obsessions, and a significant portion also noted other. And those other behavioral concerns included independent living, attentiveness, communication, life skills, sensory, wandering or elopement, sibling issues, self-stimulation, social appropriate behavior, and school behavior. And these were all qualitative responses that the parents were allowed to write in. Parents also reported on intervention needs, and in doing so, they discussed the independence of their child, and over 50% reported that their child needs help or cannot dress themselves or indicate when he or she is sick or hurt. Just over 50% can independently toilet, request things that he or she needs, and request things that he or she wants. Intervention needs that parents identified that were more than 10% include anxiety, sleeping problems, aggression, toileting, and running away. Parents were given a list of services and asked whether they receive but need more, not receiving but needs, or are not receiving. If you'll look at the top 5 that the parents noted that they were not receiving, but that their child does need, these included transitional planning, parent mental health counseling, social skills training, family counseling, and play therapy. If you look at the asterisks, over 10% in this group also reported that they are receiving this service, such as social skills training, behavioral interventions, and occupational therapy. However, they felt their child would benefit from more of these services. So the summary on what we found from our ASD supportive service needs assessment: the provider perceptions were that they need supportive services and therapy, family support, including parent, sibling, mental health counseling, and support groups, and that these were met with also a number of funding shortages that limit their ability to provide these services. Family needs: over 1/3 reported transitional planning, parent mental health counseling, social skills training, and family counseling were needed. So this demonstrates similarities among supportive service needs between both families living with a child that has an ASD diagnosis and the perceived needs of providers in the local area. Local research and existing research that will be discussed in the next segment provide evidence on the need for family supportive services in the greater New Orleans area.
Next, we have Dr. Charles Coleman. He is an assistant clinical professor, child psychiatrist, and leader of the LSUHSC Autism Spectrum Disorder Clinic at Children's Hospital. He will be discussing research related to autism spectrum disorder and family level stress.
My name is Dr. Chuck Coleman, and I'm a child psychiatrist on faculty at the LSU Medical School in New Orleans. Today, I'm going to talk to you about family characteristics that we know about through the scientific literature regarding autism spectrum disorders. I'm going to first give you an outline. We're going to go through 4 characteristics that we look for in ASD families. One is I'll discuss chronic severe stress in those families, psychological problems of individuals within the family, and the functions and roles within the family and how that's affected by autism spectrum disorders, and finally, social isolation. Chronic severe stress will be covered first. Both measured and perceived stress is higher in autism spectrum disorder families when compared to normal controls, other developmental delays, or medical illness. The aggressive behavior component of ASD leads to the most stress. The severity of the behavior problems is directly related to the level of parental stress. And the stress on the ASD family is cumulative and increases over time. Fathers report stress associated with the child's lack of communication ability and attachment. And fathers also report a high concern regarding the well-being of the mother who is the caretaker. The stress affects the parental response to treatment and parent training. To me, this is one of the most important things to remember when you're dealing with families of ASD children, is that the disorder themselves and the children's behavior will shape what kind of parents these are going to be. The idea that parents only influence child's behavior in a unidirectional way has been shown not to be true with ASD families especially, but is a bidirectional effect. The effect, the stress of raising the child affects responsive parenting, and this may lead to impaired emotional regulation within the child. Psychological characteristics of individuals within families, we talked about next. The mothers report higher levels of anxiety and depression when compared to normal controls or to those with other developmental disabilities, meaning that there's something special about autism spectrum disorder patients that tend to cause higher levels of anxiety and depression compared to children who may have intellectual disabilities or other medical problems to explain their developmental disabilities. The mothers experience twice as much fatigue and work disruption compared to parents of neurotypical children. This not only affects the mother's general sense of well-being and the mother's ability to respond emotionally and to the child, but also may start a cascade of events that can actually lead to further stress due to economic and social difficulties the mother may experience due to the fatigue and work disruption. Sleeplessness contributes to parental depression. And avoidance coping behaviors are utilized more compared to families with neurotypical children. Caretakers express feelings of inadequacy and incompetence. There is evidence that ambiguous loss is common and is very misunderstood with ASD children. Ambiguous loss implies that the child is not lost in the sense of a child who may have died or been taken away from the home, but the child is present but is somehow missing, meaning the child that you thought you would have is not present. Frustration and confusion are often due to the lack of explanatory models, especially in the early years after diagnosis. This emphasizes the importance of psychoeducation regarding ASD children as a critical part of family training. Parents must struggle with changing expectations for their future, for the future of their child, and their personal thoughts regarding the disability. Parents of ASD children are more likely to express strong moral or religious standards, which may be protective, we think, in terms of maternal depression. Acceptance and mindfulness practices can mediate the relationship between the child's behavior problems and measures of paternal well-being, paternal depression, and maternal anxiety, depression, and stress. A sense of coherence, in other words, that the world is manageable, comprehensible, and meaningful, does improve parental well-being. The third thing we'll cover here is functions and roles within the family. Families of ASD children are more directive and managerial in decision-making. This includes how they parent neurotypical siblings of the ASD child. Children with ASD present poor communication leads for others to follow, have more negative displays of affect, and do not give clear emotional signals. This lack of clear signaling that ASD children give to the parents shape the parent's response and can make for some atypical parent-child interactions. Therefore, parents may become directive of the child's attention, giving the child limited opportunity to improve their skills. This is described as synchronous versus asynchronous parenting styles for those of you that would like to read more about this particular type of parent-child interaction. There's a link between joint attention and emotional self-regulation. Increases in synchronous parenting styles lead to improved communication. The language level of the child is an important predictor of synchronicity. And repetitive behaviors from the child contribute to asynchronicity. Other important characteristics, things that I believe need to be addressed very early in treatment, are what we talk about in terms of expressed emotions. Originally, expressed emotion literature was explored in families of schizophrenia, but it's been also looked into with ASD families and is thought to be a major contributor to family dysfunction and to emotional dysregulation in ASD children. There's a well-established link between family criticism and emotional over-involvement and schizophrenia. In families that are critical, very expressive of their emotion, very emotionally attached to each other, schizophrenic patients tend to have more relapses. This has been replicated in children and adolescents with developmental disabilities. The effect appears to be unidirectional, with expressed emotions leading to externalizing behavior in the ASD child. There is some limited evidence that this effect is bidirectional. However, I think initially it should be assumed that if the parents can improve in their expressed emotions, that externalizing behaviors will decrease with the ASD children. Family criticism has a much greater influence than emotional over-involvement. Fathers are better reporters of the overall family functioning than mothers. The question about this is, are mothers more focused on dyads and fathers more focused on the whole family interactions? I don't know if this is well understood. The point is, it is important to always have families, when you meet with the families, to make sure the fathers are present and able to give their observations and input into the family's functioning and be a vital part of the therapy. Fathers report family independence as a predictor of low negative interactions. Families report low levels of marital intimacy. This lack of marital intimacy can lead to further stress and fragmentation within the parents, and can also lead to divergent parenting styles that are not reconciled. High levels of cohesion and independence and low levels of enmeshment and disengagement lead to fewer negative parent-child exchanges. Housework is greater than matched neurotypical families. Important thing to remember that it's just the day-to-day life of a family is much more difficult with an ASD child in terms of the most basic patterns, meal times, bedtimes, bath times, just even getting the house cleaned up and everything is much more difficult. And many times families need some psychoeducation to help them understand how to prioritize things within the family in terms of housework. Siblings of ASD children are hypervigilant to conflict and may protect the disabled sibling by deflecting parent negativity. Overall, siblings engage in more negative interactions in families that have an ASD member. Parents of ASD children develop more specialized parenting approaches. They may become more of a coach and a caretaker rather than what you would find in a typical family. They may have a training priority where they are demanding, strict, and anxious. It may be relationship based when they focus on mood and they tend to be overly tolerant. It may alternate between the two, where they are overly strict sometimes and at other times overly tolerant. This is very frustrating and confusing from the child, and the parents tend to feel inadequate as a result. And then when they ignore or let things go, letting alone, the parents can become powerless and helpless. In rural settings, family members may take on a quieter role due to lack of resources. In other words, in an urban setting, you may have teachers involved, ABA therapists, speech therapists, access to advocates and agencies that advocate for children. In rural areas, that may not be available, and the parents may have to not only use typical parenting roles, but have to become more of a coach, a teacher, their own advocate, and a therapist. Initially, this may look like enmeshment or seem like a pathological pattern, but it's certainly my belief that in rural settings this may be necessary. Social support is the fourth dimension we'll look at. And when a family has the perception of social support, it does improve stress management. One question is the MD or therapist part of this too? If so, this should be embraced and keeping in close contact with the families by telephone, providing them an opportunity to talk about problems other than just dealing with the ASD child may actually help with their stress management. In my own practice, I certainly do this and have a list of patients that I'll call on a regular basis just to check in and see how they're doing as parents and how comfortable they are with the current situation. Outside friends and family support improve maternal depression. Spousal support has the most positive effect on family coping, measures of adaptability and cohesion. Another reason why there needs to be a lot of attention paid towards marital functioning and how the husband-wife dyad is working and making sure that you maximize the positive aspects of their relationship. It may improve just overall functioning for the family and the ASD child. This is the end of the presentation discussing the review of literature regarding families and ASD children.
Following, we're now going to have Dr. Philip Stepka. He is a clinical assistant professor and psychologist. He specializes in clinical child and family psychology and is the coordinator for family-based services with military families here in New Orleans. Dr. Stepka will talk about an integration of therapeutic techniques to provide for families with a child with autism spectrum disorder.
Hello, I'm Dr. Philip Stepka with the LSU Health Sciences Center, and I'll be speaking to you today on the introductory and service provision component of the Family Supportive Services model. Next slide, please. So what we were trying to shoot for the families that we're working with is a model that is efficient enough to consider the needs and the multiple demands of families, but have enough flexibility to provide adequate services. So what we shot for as our ideal was a single session model with the flexibility of add-on sessions to identify and adjust our service provision to the individual needs of each family. It involves a few different aspects, first of which is an assessment. The assessment and we'll go over this in much more detail later on in this presentation, but this is not a psychological evaluation. Really, this is an opportunity to get to know the families, to review either prior to meeting the families or while meeting the families, any prior information, whether that be assessments, collateral notes from other practitioners, but most importantly, to get to know these families and get as close of an understanding as possible to how they work and how we can help them do that more efficiently, as well as provide information or services that they're lacking. As that clearly falls into the needs identification, and what's a little more unique to our program, especially for these sessions, is how we help families not only identify their needs for us, but to prioritize those. Oftentimes our families have many things going on, and just the sheer abundance of issues to be addressed can actually act as a barrier to getting any one individual need addressed. So part of the work of these sessions is to help take an inventory of needs, as well as to provide or develop a hierarchy of those needs with the families. Once that is established and we have an idea of what the families are looking for, the remainder of the session is focused on different types of service provision. This can range from something as indirect as to providing appropriate referrals, to hands-on interaction with the families and the children to assist with particularly difficult life stressors, issues related to symptoms, what have you. And then with each session, we follow up in a variety of different formats, which we'll talk about, because one of the things that we are really striving to achieve in this model is a combination of families actively engaged in problem-solving process and a regular follow-up, so that these skills and these new patterns or practices in the families can be maintained. Next slide. So a typical session outline begins with a family assessment, and depending on where the family is in their stage of diagnosis or how long they've been supporting their family member on the spectrum, we may be providing new or corrective psychoeducational information on all sorts of topics. For families that have either received this or have already gotten past this stage in the process, we may go immediately into problem solving and supportive services in that regard, which are basically involve a two-pronged approach. One of assessing and improving family communication styles, as well as teaching them a workable, durable format for identifying, brainstorming, and implementing potentially effective solutions for their families. At the end of each session, we contract with the families to identify a plan of action and decide whatever our next steps may be. This may be the conclusion of the services. This may be scheduling follow-up appointments. It also could be, deciding to do a more extended follow-up, more of a wait and see. But each one of these sessions ending in a way to determine what the family's needs are. But more importantly, that we end with a concrete plan of action that should take place after the session and in between sessions. So in step one, the family systems assessment, depending on how you do this, this can take between 10 to 50% of the session time, particularly the first session. It can be done in a couple different formats. The family assessment can take place in vivo. You can have this be part of your first face-to-face interaction with the family. Or a lot of the information that we're going to go over can be accrued through telephone or web-based interaction to get this information. Some things can be sent home for the families to fill out. Where this model or this step changes is in subsequent sessions. So in the first session, it really is more of a typical family assessment, getting some information on, developing rapport with the family, verifying diagnosis, getting a needs assessment, identifying, who does what in the family, and quite honestly, how they feel about that. Is the distribution of roles and responsibilities something that's equally shared and appreciated by all family members, or do we identify that some members seem particularly strained and we may need to help them to maybe renegotiate different structures. We also want to identify, we don't want to reinvent the wheel. Like we said, we're trying to make this an efficient process. We want to find out what are the strengths and the resources that the families have already brought to bear with these families. A family that has been 5 years post-diagnosis and have really been working together for a long period of time are going to have different things to bring to the table than a family who just got feedback on their child's psychological evaluation the week before. So we really want to get an idea of what the families have and what they're bringing to the table, as well as what are the barriers to effective communication, effective problem solving, and effective acquisition of basic needs for themselves as well as their children. Like we mentioned, there is a difference between how this step plays out in initial versus subsequent sessions. In initial sessions, like I said, it's going to be more of a typical initial intake interview. With subsequent sessions, it's going to be more of a follow-up of the prior session's problem-solving component, which we'll talk about in the third step, where we'll follow up on the effectiveness of strategies or problem-solving approaches that were contracted amongst family members, determine to what degree those have been successful or not successful, and make adjustments as such. In other follow-up sessions, it may be, if there has been success with a previously identified problem and making some gains in theirs, it may be a brief needs assessment on what we want to work on today. Next slide, please. So a couple areas that we want to consider and take a look at in the family needs assessment. First of all, has to do with what is the typical routine and the patterns of family cooperation and problem solving. The first aspect we want to really see is what is the quality of the communication. Are people communicating, expressing their needs, making clear questions, engaging in the process with their children and with each other in a way that makes the most sense, and quite honestly, is the message being sent the one that's being received by the listener. Related to that is also, satisfaction with role distribution, as I mentioned in the first slide. To what is everyone's role? How do they all play into the larger scheme of things in this family? And to what degree is that increasing or decreasing stress among and between different family members? We also want to get a clear understanding of to what degree does a family understand autism spectrum disorders, what part is being a typical kid and what part is being a child with an autism spectrum disorder, how to tell the difference, which are the differences between maybe comorbid symptoms and issues that are related specifically to the diagnosis. And really, a mantra that has been going around in this project is, helping parents parent despite of autism. So this idea that, what are the age appropriate expectations of all children regardless of diagnosis, and what are the considerations that we need to do or the accommodations that we might need to do based on how the diagnosis may affect this child's development and their functioning. So step 2 goes hand in hand with step 3, which we'll talk about, and For families that either have misinformation or who are very new to the diagnosis of autism spectrum disorders or child development in general, we could be working with first-time parents as well, so we want to keep that in mind. We've included the psychoeducation component. And depending on which session this is, or the lack of or the breadth of information families have, this part of the session may take up 20 to 80% of the session time. So really what we want to do in psychoeducation is provide an accurate information regarding diagnosis, the course of autism spectrum disorders, and really what to expect of your child at 10 months, at 10 years, and at 60. To really give families an understanding of what's workable and what's not. So some key topics that tend to come up in the psychoeducational component is the role of family members. To what degree is it important that we're having the adults in the room and we're not sitting and doing a service where we're just providing individualized treatment or interventions to just the individual diagnosed with autism spectrum disorder. So really reinforcing and helping the family understand the important role of family in this work and participation in the program. We may need to work and debrief with the family about prior diagnostic or therapeutic experiences, or provide them information on potential referrals. So oftentimes when I work with families after they've had a psychological evaluation or a medical evaluation, they come back from the feedback of those evaluations and the reports more confused than empowered. So oftentimes it's the second or third clinician that really works with a family that kind of realizes that they haven't really been given a whole lot of great information about what's going on with their child and how they can help. And a final and very important aspect that we cover in psychoeducational sessions is the role of adult caregivers in their children's lives. As children on the spectrum grow, they grow like every other child. They go through puberty. They have more needs and needs in development with regards to privacy and autonomy, while at the same time keeping in consideration, their unique needs depending on their diagnosis and symptom presentation. So it's important to provide families, especially adult caregivers, with some reasonable expectations of their level of involvement and how those roles and responsibilities may change over time, and how to support them in those transitions, which leads us to the step 2. But a quick caveat about session 2 and session 3 with regards to single versus multiple sessions. Next slide, please. So as we've mentioned, that this is shooting for a single session model. And for some families, especially families with fewer stressors, fewer risk factors, and maybe new to the diagnosis, they may simply need some provision of some psychoeducation and consultation and referral to local resources. For families in more isolated communities with multiple stressors and multiple needs, these are going to be families that are definitely going to benefit more from multiple sessions. And it would be very difficult for a clinician to be able to provide adequate services in the single session model. As we've mentioned in different parts of this training, there are ways that we make that a little more efficient. Collecting collateral information through phone conversations and really prioritizing the more intervention strategies for the face-to-face meetings. Also for the first meeting, since it is a more extended assessment, step 1, it might be important to have a longer first meeting, so maybe 90 minutes to 2 hours, whereas follow-up sessions could be much shorter. So step 3, the problem-solving supportive therapies. This is really what we see as taking up the lion's share of session time, as well as the meat of the proposed intervention. It has some goals, but the primary goal is to reduce family distress. What the research on families with children and adults with chronic or ongoing health or mental health issues is oftentimes it's not so much the diagnosis or the disease itself that causes the most amount of stress for families, but it's the quality of their communication and collaborative problem solving capacities that really is a major risk factor. And when those areas are improved, families do much better despite, the severity or the frequency of a particular diagnosis. So 2 areas that we really want to focus on in this step is, in step 1, we really paid attention to what are the communication patterns, what are the strengths and the barriers that the way the family communicates with each other poses. And in this step, we really target those and try and improve and make them more efficient and clear. Along those lines, also, we're paying attention to how do families communicate about problems. Is this something that is primarily decided by one person, or are different people relegated to certain task solving or problem solving roles, or is there more flexibility in the family? And what we want to try and introduce is an improvement in their family communication and increase the efficiency and the collaboration in their problem identification and solving process. Next slide, please. So the typical sequence, one of the first things that we find with families with multiple stressors is they have a lot of things on their mind, and what really helps them become more effective problem solvers is really narrowing down the focus. This isn't to say that we're minimizing or ignoring other problems that the family are dealing with, but we want them to develop a method of problem solving that really gives as much attention and care to individual problems one at a time, as opposed to trying to multitask problems. As they become more efficient, they can multitask more, but we really want to start with them identifying mutually a problem that they want to work on. Some families, that's the most difficult part, is coming to a consensus on what issue to work on. So that's where the prioritization step really comes in. And we should have already an inventory of the problems that are on the family's mind from step 1. For those of you who are familiar with problem-solving strategies, these things should be, a pretty old hat. The first step of which is having all family members together brainstorm for multiple solutions to the difficulty. And to brainstorm these solutions prior to providing any evaluations of any of these solutions or choosing a particular solution to pursue. Oftentimes with families, a person will come up with an idea and it's immediately shot down or it's immediately implemented before it's really even discussed or the potential pros and cons have really been evaluated. And what we want to do is help families slow down a little bit. All their time between our sessions are very hectic and they have lots of responsibilities. What we really want to give them in this session is an opportunity to really slow down and think through how they identify and how they solve problems together. Once an inventory of the potential solutions is developed, we have them go through a pro-con or a cost-benefit analysis of the different solutions. And maybe if individual solutions don't work out so well, we might be able to combine a few to come up with a more ideal solution that's palatable to the majority, hopefully all, but at least the majority of family members. Then what we want to do is discuss with specifics how and who is going to implement the plan and how this is going to be coordinated. And then in follow-up sessions, we want to plan and evaluate the effectiveness of these different interventions. If they are effective, we move on to the next difficulty. If they were not as effective as we wanted to be or were not effective at all, we want to reevaluate and start the process over. So helping families really stick with one issue before lily padding to multiple issues. So what is your role during this process? So a couple things to keep in mind is it's not necessarily your job to come up with the solution. Uh, as clinicians, we are going to have information on evidence-based approaches for very specific clinical issues. And many of those my colleague Dr. Callahan is going to go over in the next session. But for the majority of the problems of daily living, families should be able to develop their own workable solutions. What our job is really to provide an environment for them to explore those options in much more efficient and effective ways. So part of it is helping them prioritize the problem. Also for family members with difficulties with attention span or who may be used to being the decision maker and struggle with other people being involved in that, it'll be the therapist's role to help redirect members to stay on topic, but also to allow other people to have their voices heard if one or more people tend to take up the airspace. Whereas other people tend to be quiet. So this is be a real opportunity to help quieter family members or family members who tend to have smaller voices have their ideas heard. Oftentimes with families that are struggling is some of the people with the best ideas get the least opportunity to express those ideas or have those heard and genuinely considered. During this time, the therapist is going to be observing and paying attention to the quality of the communication with the families. And if they're really struggling with basic active listening or effective and appropriate communication strategies, the therapist may do breakouts to help with that, to improve listening skills and improve verbal expression skills as well. As we talked about, sharing the air in families is an important quality, and therapists being aware of to what degree are people withdrawn or hijacking the session and seeing if they can establish a little bit more equanimity across caregivers and their ability to get their ideas out there and discuss with each other. And then the last piece, probably the most important piece, is making sure that follow-up sessions begin with a discussion of the prior session and the prior contract. Before moving on to the new crisis of the week, we want to focus on what was the target of last session, what was the quality, how satisfied were the family with the outcome of the intervention, and do we need to revise? So here, I'm not going to go over these in detail, but here are a lot of hot topics that tend to come up in the problem-solving sessions. Everything ranging from, daily routines to getting the kids out of bed, to crisis management and self-harm. A lot of the more serious difficulties or more recurring difficulties more specific to children on the autism spectrum is going to be covered in more detail in Dr. Callahan's talk following this one. So step 4, this should really be 5 to 10 minutes for those of you regularly seeing clients and families. This is probably not a whole lot different than what you typically do, but really just wrapping up the session. Oftentimes, problem-solving discussions can get very energized. So this is really an opportunity to repackage everybody before we leave. So the goals really are to provide a clear closing end to the session. Lots of topics and lots of ideas may have been discussed. This is an opportunity to really review and clarify that everyone is on the same page. This is particularly important with regards to problem-solving sessions where some people may be under the impression that different plans of action were decided upon, or others think something else is going on. So this is really an opportunity for the therapist to encourage each member to summarize what everyone has agreed upon in their own words and to make any corrections as needed. This may also be where we decide, what are some of the follow-up actions between sessions, whether that is following up on future referrals, other services, what have you. And we also decide, are we done? Are we going to meet again? Do we need to do a follow-up session? Does it need to be in person, or would a phone consultation be sufficient? Next slide, please. And that brings us to step 5, the follow-up. We have lots of flexibilities with the follow-up sessions. They can be in person, or they can be through Skype or through telephone. With families who have that ability, it might be useful to, if we're doing tele follow-up or teleconsultation, to have a chance to have the whole family in the room talking. Oftentimes, one of those communication patterns that we have to deal with is sometimes one family member acts as the spokesperson. And if you've ever played a game of telephone, sometimes the message that is conveyed to one person is transformed by the time it's reached the third or fourth person. So really being able to treat the family unit as a family unit and avoid as much as possible just dealing with individual spokespersons for the family. So the goals of the follow-up are to follow up on the prior referrals as well as the problem-solving contract, if we focused on that in the prior session. To debrief and to process any barriers that got in the family's way. Very important with these families is, regardless of the level of success in their implementation, is to reinforce their efforts for doing so and to really maintain their hope in the process. Our families do so many things. There is no shortage of efforts that we can highlight and reinforce and praise them for, because they really do work so hard for their families. Don't let levels of frustration or distractibility be an indicator of how hard the family is working, because usually that's because their mind is on something else that is also very important for their families. So this is really an opportunity to celebrate with them their efforts, and especially their successes, but efforts nonetheless. This is where we also be revising plans of action and determining what the next steps may be. So in our, after a previous session, we may have decided that we were just going to do a follow-up phone session, and now the family may be in a different place where they want to have another face-to-face. They may also discover some other issues. New evaluation results may come in and find out that the family needs additional services, and we can help them identify and pursue those as well. So that is the end of my presentation. I hope this was helpful and gives you somewhat of an overview of the what a typical session format would look like in our pilot study. I hope you enjoy the rest of the talks today, and have a good day.
Okay, finally, we're going to have Dr. Kristen Callahan. She's a clinical assistant professor and developmental psychologist. She's also the director of the LSU Health Sciences Center Assessment Clinic. She will discuss the integration of these family supportive techniques with addressing frequent behavior concerns for children with autism spectrum disorder.
Hi, I'm Dr. Kristen Callahan, a licensed psychologist and assistant professor at LSU Health Sciences Center School of Medicine. And I'm going to be taking a few moments with you today to talk about problem-solving supportive therapies for high-frequency problems in autism spectrum disorders. The following 6 problems are high-frequency problems among children and families with ASD. I'll be talking about different ways to help alleviate and alter some of the maladaptive patterns families often find themselves in when navigating self-stimulatory behaviors, sleep, routines, self-care, family functioning, and role distribution. So what is overstimulation? It's when children are swamped by more experiences, sensations, noise, and activity than they can handle. If you think about the 5 senses, you think about hearing, sight, smell, taste, and touch. Most children on the autism spectrum experience either one or perhaps all of these senses to a heightened capacity and can easily become overstimulated and engage in self-stimulatory or stereotype behaviors as a result. However, important to note, typically developing children can also become easily overstimulated when their senses become swamped by any or all of their 5 senses as well. So what are the common signs of overstimulation? Can be broken down really into 2 components, emotional and behavioral. Emotional, irritability, crying, angry angry outbursts are often misattributed to misbehavior and defiance. Alternatively, they could get overly excited. Children may have difficulty focusing. They jump from one activity to another, become overly impulsive. Unfortunately, if you're a student of mine, especially in regards to psychological assessment, you hear me say time and time again that everything looks like ADHD: difficulty focusing, unable to keep still, etc. When the reality is only a fraction of children suspected of having ADHD actually do. So one factor we commonly associate with ADHD symptoms is overstimulation. This is even more pronounced and important to recognize in children who are on the spectrum. Alternatively, children may not be able to focus and may be overactive, but they may exhibit signs of being sleepy, such as yawning, rubbing their eyes, and just being really tired. On the behavioral side of things, and some of the behavioral signs is that they may avoid touching or being touched. And that's because one or more sensory inputs may be too much for that child. Or they could refuse to participate in activities or interact socially. But you have to be careful because that might be just a part of ASD. They could cover their eyes and ears in response to visual or auditory stimulation that is just overstimulating. Make poor eye contact or avoid it altogether. But once again, that can be a sign of ASD as well. Or they complain about noises that don't really affect others, such as vacuum cleaners or hair dryers, or the small sound a television or laptop makes whenever it's buzzing, or other background noise that typically developing persons have really become accustomed to. More common for children on the spectrum are overstimulation in regards to televisions and movie theaters, video games, grocery stores, malls, fireworks, and so on, that are not as stimulating for typically developing children. So some less common culprits for typically developing children, but maybe culprits for overstimulation for children on the spectrum, are the school classroom and the home environment. I've conducted many school observations of children suspected of being on the spectrum because of odd behavior at school, only to find that the school environment was really overstimulating. Brightly colored walls and tactile stimulation on the walls that they could touch. And each classroom had between 20 and 25 children, which led to the noise being really high. Music that was always utilized in the background, etc., all made for a really overstimulating environment. So that's just something else to be mindful of when considering interventions targeted towards the reduction of sensory input at both school and at home. So you can calm an overstimulated child by reducing the noise and activity level around your child. So turn off the television or radio and take your child into their bedroom, or let them spend time near you if that's what they need to wind down. Sit quietly with your child and choose a calming activity such as reading a story, completing a puzzle, lying down with them, singing some quiet songs, or just stroking their back or rocking in a rocking chair. Help your child put words to feelings that they are experiencing through their behavior. For example, I can see that you're really frustrated right now. This is equally important to do with both verbal and nonverbal children on the spectrum. These strategies really help you become increasingly aware of the possible trigger in your child's environment, and work to avoid those triggers and learn what calming techniques work best for your child. A second high-frequency problem is sleep. For parents, you are not operating optimally if you are tired and irritable. Your children sense this in your mood and your actions, and you're actually more likely to parent harshly. This also directly impacts marital and partnership quality in the ways that you would expect through decreased intimacy. For children, the long-term effects can lead to obesity and cardiovascular disease. And as well as we would expect, they may be grumpy and have an irritable mood. But like I said earlier, everything seems to look like ADHD, and for children, the lack of sleep can look like sleepiness, such as falling asleep in class. But more often than not, children actually look more hyperactive and impulsive with an inability to focus. So two main reasons parents and children experience a lack of sleep, and those happen between two different kinds of co-sleeping practices. The use of unintentional or reactive co-sleeping, which is your child comes into your bed at night, but in theory, they're supposed to be sleeping in their room, versus intentional co-sleeping, which is your child sleeps in your bed every night for the whole night, and this is a long-standing pattern. So how do you break these patterns? For unintentional reactive co-sleepers, you need to think about how your child falls asleep, because this is the key to a successful night's sleep, such as, are you always present when he falls asleep? Do you turn out the lights and then have to go back in to settle him? Does he come out of the room multiple times until you lay down with him? So for example, if it's the case that you're always touching your child while they fall asleep, I've suggested weighted blankets or bean-filled gloves to be placed on the child to aid in the extinction process. So for early risers, it is really tempting just to surrender to the 4 or 5 a.m. When your child slides into the bed with you. But if you want your child to stop this behavior, they will not do it on their own. One idea is to use an okay to wake clock that is set to about 10 minutes after their usual wake time at 4 or 5 a.m. and then move it back 10 minutes later per day until you've reached the desired wake time. For children who come into your bedroom on their own, you can provide them with an option for sleeping in your room without disturbing you, such as a sleeping bag and a pillow on the floor. Many children stop using the sleeping bag after a period of time, realizing it's not as comfortable as their bed, which is what you're going for. If your child does not want to sleep on the floor and insists on disturbing you every night, you need to walk him back to their room every single time. Close the door to signal the expectation that he will stay in bed. If he gets up and leaves the bed, you close the door for 1 minute, holding it shut. If you open the door and he is not in bed, you close it for 2 minutes and increase this time as needed. So what's most important during the extinction process is to first be consistent in your attempts. If you give in just every once in a while, you will reinforce the behavior you are trying so hard to extinguish. Second, make a plan. To be consistent, you have to know exactly what you're going to do ahead of time. Third, create a start date and do not start a change the day before other changes, such as going on a trip or having visitors and family come in from out of town. Make your child's room fun and special by spending one-on-one time in their room with them. Have them pick out new sheets or sleeping clothes or special decorations for their room. It's not fair to expect that your child to start sleeping all alone in an unfamiliar place. So you may want to move into your child's room for about a week before starting to withdraw your presence. Establish a routine. Put your child to bed at the same time and in the same way every night, such as first putting on pajamas, then brushing teeth, then reading 2 books, then doing something just the two of you share together, such as singing a lullaby or 2 kisses on each cheek and then an I love you. For breaking the cycle of intentional co-sleepers, where the intent was to co-sleep, the process may be a little different. First, discuss with your child that a bedtime transition is about to occur, that they're a big girl or boy and they are ready to spend the night in their own bed. Start moving bedtime routines into your child's room. And if your child is still napping during the day, this is a good opportunity to have your child practice sleeping in their own room. Moving your child's bedtime later and later can also be a big help with this transition into their own room. As I mentioned earlier, camping out in your child's room, it might be used by using an air mattress or a sleeping bag on the floor, but not sleeping in the same bed before they are expected to sleep alone will ease this transition. So other questions you may have: how long will this take? It can be really hard to predict, but typically no longer than 2 weeks. So some children are more ready for the change than others. What if my child gets sick or has a nightmare? Continue and try to follow the plan as strictly as you feel comfortable. A quick cuddle in the middle of the night in their room is okay. Bringing them into your bed for the rest of the night may undo weeks of hard work. After your child is successfully sleeping in their bed for about a month or so, bringing them into your bed is really what you have to do in cases of high fever or vomiting. It is okay, but you have to understand that you may have to be a bit firm afterwards. And what if I'm not sure if I'm doing the right thing? If you are ambivalent, your child will know, and you are setting you both up for failure. And I recommend that you wait until you are sure of your plan and confident that you will follow through. Thirdly, the importance of creating and adhering to routines for both typically developing children and those on the spectrum cannot be emphasized enough. Children are able to thrive, learn, and explore in environments where they know what is expected of them. You don't have to consistently tell the child what to do. They already know. They learn self-control and the ability to wait when they learn that there is a time and a place for each activity. Routines reduce stress and anxiety for each family member when they know when to expect certain things and what is about to happen next. Over time, children learn what is expected of them, whether it be brushing their teeth or packing their book bags, without constant reminders. Knowing when certain activities will occur allows children to look forward to activities that they enjoy at certain times of the day, and routines help build in times during the day to connect with your child by building in connection rituals into the daily routine. Now, routines establish a secure and safe foundation for children by which other skills and experiences can be promoted, such as learning, building secure attachments, and promoting social engagements. Foundations of safety and thus routines, however, are of great importance when talking about behavior. If you think about a pyramid and safety as the foundation by which it is structurally sound, then behavior is really your barometer or your gauge to know that there have been disruptions in a child's routine or otherwise safety. It doesn't take much of a shift in safety to make significant shifts in behavior. Fourthly, the first component to self-care is to realize the impact overscheduling has on children. Families with children on the spectrum regularly fall victim to overscheduling due to the recommendations by treatment providers and expectations that they engage their children in multiple treatments and activities outside of school to somehow make up for whatever services school may or may not be providing. Similar to the signs of sleep deprivation, children who are overscheduled may be irritable or cranky or complain of physical ailments such as their head or their stomach hurting and fall behind at school. In any instance, children are then not able to fully engage and absorb the important information at the many outside activities. Knowing how much time is required of each outside activity and its perceived benefit to your child is the first step towards prioritizing your child's activities in an effort to not overschedule. Allowing some flexibility in missing sessions or practices is okay, and it is equally important to balance the activities of all of your children, those on the spectrum and those not. Make family time a scheduled activity and treat it as an important component to your weekly schedule. Know when enough is enough and it's time to call it quits on some activities. In addition to overscheduling, there are a number of stressors that occur in all families, those with and without children on the spectrum. During the course of a marriage or a partnership, there will undoubtedly be disagreements in finances and child rearing. However, this is especially true for families with children who are on the spectrum due to the increased likelihood that one parent may have to stop working in order to care for a child who is on the spectrum, or pay for additional treatments and services, and more likely to engage in disagreements about what is best for that child by way of discipline and parenting. Breakdown in communication between spouses may occur in any relationship and has routinely been shown to be the biggest predictor of problems within a relationship. Finding a communication style that works for you and your spouse is key to communicating effectively. It goes without saying that around 50% of marriages will end in divorce, leading to an increased number of parents either single or co-parenting. Single parents often wear multiple hats, such as they're the cook, they're the teacher, they're the disciplinarian, the chauffeur, etc. And for kids on the spectrum, this can be really difficult for them to navigate exactly which hat is this parent wearing now. Because of the many stressors that come with parenting a child on the spectrum, parents have the likelihood to be overprotective. Being overprotective means that you, as a parent, may be nervous to let your autistic child try new things or let them feel the consequences of disappointment. This mindset may lead to attempting to solve all of your child's problems for them, worrying about them constantly, not tasking them with chores around the house, thus creating animosity between siblings, and ultimately failing to educate your child and prepare them for the real world. When parents are overprotective, it obstructs the child's learning, and they do not develop the capacity to handle situations on their own. They will always look to their parents for the answers. When parents protect their child too much in an effort to make their child's life stress-free, it really has the opposite effect. Children begin to feel that they do not have enough control over their lives and the decisions that they make. All children want to feel protected, but yearn to have control over the direction and the decisions that they make. Most important for parents with children on the spectrum is the importance of having those children gain confidence by working hard and mastering tasks on their own, just in the same way that typically developing children and adults do. When parents continue to do tasks for their children, those children have not been given the opportunity to develop adaptive, lifelong self-help skills. So what can parents do to be less overprotective? Teach your child right from wrong and have confidence in your teachings that they are capable of making some decisions on their own. Before you rescue your child from a problem, give them time to see how things will turn out. This will give your child the opportunity to make a decision even when they're overwhelmed. It may take some guidance from you, but see them through it. Overprotective parents tend to tell their children what to do. Instead, you should learn how to listen to your child's cues and offer help when it's needed. Before you decide to help your child with a difficult situation, it's important to first think about the worst case that will happen. If it's something bearable, you can let your child go through it and only intervene if you feel your child might be in serious danger. Let your child have the consequences of their decisions and behavior. They will learn from these behaviors unless their immediate safety is involved. Let no be a part of your vocabulary. Do not allow your child to get everything that they want. Some parents feel bad and guilty saying no to a child who's on the spectrum, but in the end, they will not always get what they want. When growing up, children have their parents as their advocates. As they develop and gain new skills, let them be their own advocate and make it possible for them to speak up for what they need. The most important task you can do as a caregiver of any child is to engage in meaningful self-care activities. Caregiving is hard work and can lead to detrimental impacts on your sleep, diet, physical, emotional, and mental health. Self-care is not selfish. It may be hard for a parent to ask for help in any instance, especially when it comes to meeting their own needs. Some parents may feel responsible for the fact that their child has a spectrum disorder, and thus may feel that they don't deserve to have time to themselves doing something that they enjoy. So understanding why some parents may feel guilt for seeking out help or finding time for themselves is an important step towards self-care engagement. Self-care modalities include physical, psychological, and emotional components. Physical self-care includes diet, incorporating exercise, adequate sleep, and seeking medical care when it's needed for the caregiver. Psychological self-care includes making meaningful connections with someone outside of friends and family that seeks to provide an outlet that is therapeutic, such as journaling thoughts and feelings, or engaging in meditation and relaxation activities. Engaging in self-care is not just important, but vital for parents with children on the spectrum. And it is strongly, strongly encouraged that it be a top priority, not only for the function of the parent, but the child as well. Emotional self-care is doing what you find fills up your cup, whether it being with supportive people or spending time alone. Doing something nice for someone else or referencing nice messages you've received from others are good reminders of the positive impact you have on others.
So that concludes the overview of information from the NOLA Family and Community-Centered ASD Support Project. We hope that you were able to get information out of this webinar that you may be able to use with your families, children, students, or consumers at your organization. So as a wrap up, we would now like to allow you to provide any feedback on the manual that we're developing. You can go to this website and complete the form to provide any input that you feel will be helpful to include in the manual. We're going to compile all of the different suggestions that we get from people who listen to the webinar and continue to work on the manual. And then once we have it complete, we're going to actually send you a copy of the product. For those of you that are completing this webinar for continuing education credits, please, please, please just be sure to complete the evaluation form that we send you via email. We're going to send it to the email that you provided at registration. If you have any other questions or comments or concerns, once again, feel free to email me at cbark1@lsuhsc.edu. And once again, thank you so much for your participation in this webinar and any feedback that you provide.